Thank you everyone for joining us, and welcome to the Cancer Research Institute's webinar series, Cancer Immunotherapy and You. Today's date is Thursday, April 28th, 2016. The title for today's webinar is Momentum in Head and Neck Cancer Immunotherapy. In this webinar, we'll discuss current immunotherapy treatment options for patients with head and neck cancer. This webinar series is presented with generous support from Genentech and LabAnswer and its employees, and the following. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. Cancer Research Institute is the world's first organization dedicated exclusively to harnessing the power of the immune system to conquer all forms of cancer. We fund scientists all around the world whose work has led to significant breakthroughs in cancer immunotherapy research and treatments. Over the next 30 minutes, you'll have an opportunity to hear firsthand from an immunotherapy expert how these breakthroughs are transforming the treatment of head and neck cancer. After a 15-minute presentation from our speaker, we will open up the discussion to questions posed by you. You can pose your questions at any time by typing in the Q&A box on your screen. You can also tweet your comments to us using the handle @CancerResearch and the hashtag CRIWebinar. Now, it's my pleasure to introduce today's expert speaker. Dr. Jonathan Schoenfeld is a radiation oncologist at Brigham and Women's Hospital, Dana-Farber Cancer Institute, and assistant professor of radiation oncology at Harvard Medical School. His research focuses on the design and implementation of clinical, epidemiologic, and translational studies in head and neck and skin cancers. His research has been featured in the New York Times, the PBS NewsHour, and the Washington Post. Dr. Schoenfeld, we're grateful that you could take time out of your busy day to be with us today. Welcome.
Thank you. Thanks very much. And thank you so much for the invitation to speak today. I think this is an extremely exciting time in the field of immunotherapy, and particularly immunotherapy to treat head and neck cancer. And hopefully I can share that excitement and the momentum that I think is building here today. I also wanted to thank the Cancer Research Institute for supporting this webinar series and their support for immunotherapy over very many years that I think has helped to make this such an exciting time for development in head and neck cancer. Now, I wanted to start very briefly with this relatively old picture that shows patients waiting in line to receive the polio vaccine soon after it was first developed. Because I think it illustrates how vaccination, which is really the first successful immune therapy, revolutionized the treatment of infectious disease in ways we really don't think about very much anymore, but are really one of the most impressive advances of medicine in the modern era. I also wanted to mention it because it was personal motivation for me. Having pursued a career in cancer treatment and research many years ago, largely because of the all too familiar story of a family member who died of cancer, I entered research with the hope that we were perhaps just a vaccine away from curing cancer as we had for polio. And this idea of using the immune system to do something traditional chemotherapy has not been able to do, cure cancer, continues to motivate me to this day to continue to develop new treatments for head and neck cancer patients. As another historical note before we move on, given I'll be speaking about immune therapy and head and neck cancer, and this webinar series is produced by the Cancer Research Institute, I did want to point out that perhaps the first treatment with immune therapy for cancer occurred for a patient with head and neck cancer, and was administered by the father of the founder of the Cancer Research Institute, Dr. William Cooley, shown here. Dr. Cooley was a surgeon practicing in New York who noticed that some patients with severe infections could have regression of their tumors, presumably because of activation of the immune system. Because of this observation, he decided to inject patients with bacterial products, which came to be known as Cooley's toxins, to see if he could recreate this phenomenon by stimulating the immune system. He performed his first inoculation in 1891 on a patient with a cancer of the head and neck. Very interestingly, this patient had a complete response following Cooley's initial treatment and was able to live an additional 8 years after he was expected to die just weeks after he was first seen and treated by Dr. Cooley. Over the subsequent decades, we've gained a much deeper understanding of the immune system and how it interacts with infections and cancer. This diagram illustrates what we know now about the two main arms of the immune system. The innate immune system, pictured on the left, is the body's rapid response system that represents a first line of defense against infections. It also helps set the wheels in motion to activate adaptive immune responses, shown on the right. Adaptive immune responses are special in that they are long-lived, they can last for years or even decades, and they're specific. For example, an adaptive immune response might recognize one type of infection, but not others. Adaptive immune responses include B cells that produce antibodies, as well as T cells of various different types. There are many key players biologically in immune-mediated attacks on cancer cells, but perhaps the most important is the T cells that I mentioned. In this drawing, you can see what it might look like if we were able to zoom in and see the power of T cells to seek out and destroy cancer cells. The body typically has over 1 million T cells per milliliter of blood, and many more T cells that aren't in the circulation at any one time. So when you add them all up, there are more T cells currently in most people's bodies than there are stars in the Milky Way galaxy, which represents a powerful army if we can harness these T cells properly to cure cancer. Because the T cells are so powerful, they need to be tightly controlled to prevent damage to the body under normal circumstances. In order to tightly control these T cells, they normally have a range of both activating and inhibitory receptors. As you can see on the right, the activating receptors, many of which have been recently identified, are shown in blue. These activating receptors act like the accelerator or gas pedal in a car. They respond to danger signals and help turn the T cells on to respond and attack. On the other side of the diagram are the immune checkpoints. These are shown in yellow, orange, and red. If the activating receptors are the gas pedal, then these inhibitory receptors are the brakes on the immune system that are important normally to make sure the immune system doesn't get out of control and cause damage in the body. These brakes are otherwise known as immune checkpoints. And while they normally play a very important function in the body, unfortunately they can be manipulated by cancers. Two of these inhibitory receptors in particular, shown in the box, have been identified as very important to cancer development: CTLA-4 and PD-1. Cancers take advantage of these proteins to evade immune attack. Fortunately, over the past couple decades, drugs have been designed to specifically target these CTLA-4 and PD-1 proteins to allow the immune system to fight cancer cells that are present in the body. So to review, tumors actively evade the immune system. Under normal circumstances, there is something called immune surveillance, where the immune system seeks out and destroys early cancers. However, over time, some of these cancers potentially find a way to coexist with the immune system, potentially via avoiding notice, creating a situation known as immune equilibrium. Eventually, using inhibiting mechanisms such as the immune checkpoints that I just talked about, tumors escape by actively suppressing immune responses. These cancers are then able to grow and spread. The different types of immune therapies that have been designed counteract the different ways that tumors escape the immune system. Vaccines, for example, help the immune system recognize cancers and differentiate them from normal parts of the body. Immune activating signals and certain types of immune checkpoint blockade tell the immune system that tumors pose a threat and need to be eliminated. T cells can be grown and engineered outside the body and then infused back into patients, helping to expand existing immune responses. And finally, checkpoint blockade such as inhibitors of the PD-1 checkpoint receptors that I just showed earlier, help overcome ways that tumors suppress the immune system. These different types of immune therapies have demonstrated extraordinary success over the past several years, leading Science magazine to declare immunotherapy in cancer a breakthrough of the year. Immune checkpoint blockade is now approved by the Food and Drug Administration to treat various cancers such as melanoma, lung cancer, and kidney cancer. And vaccines and other types of immune therapy are also approved to treat cancers such as melanoma and prostate cancer. Immune therapy has achieved breakthrough status in cancers such as lymphoma, bladder cancer, sarcoma, colorectal cancer, Merkel cell cancer, pancreatic cancer, and leukemia. And there is ongoing rapid development of many different types of immune therapies, including vaccines, drugs, and engineered immune cells. To talk about head and neck cancer specifically, for anyone in the audience who's not familiar, the head and neck has a complicated anatomy and an important immunologic function, as it is the route of entry not only for many infections, but also for the healthy foods that we eat and the airs that we breathe. Unfortunately, the head and neck is also the source of many different types of cancers that occur in different regions. For example, the nasopharynx behind the nose can give rise to nasopharynx cancers. The oral cavity has its own cancers. The oropharynx is behind the oral cavity with the tonsils on the base of tongue, and this can develop cancers, as well as cancers of the larynx or voice box, the hypopharynx, the salivary glands, the paranasal sinuses, and the skin. So many different types of cancers can occur in the head and neck region. Head and neck cancers are often caused by the chronic damage associated with long-term alcohol or tobacco use. But interestingly, an increasing number of head and neck cancers are also related to viruses. For example, tonsil and tongue cancers can be related to the human papillomavirus, or HPV. Nasopharynx cancers can be related to chronic infection with the Epstein-Barr virus, or EBV. And a rare type of skin cancer called Merkel cell cancer can be related to a virus called the Merkel cell polyomavirus. Current treatment for head and neck cancers balances effort to treat the cancers appropriately, but also maintain a good quality of life. Because obviously the head and neck is very important for speaking, swallowing, breathing. Therefore, there's a large importance of what we call multimodality care, which means that for a single tumor or a single patient's cancer, there may be a combination of surgical approaches, radiation, as well as chemotherapy that's used. Despite recent improvements in all of these, surgery, radiation, and chemotherapy, treatment for head and neck cancers can unfortunately still be associated with long-lasting or even permanent side effects. There is also a pressing need to improve outcomes for head and neck cancer, given it's one of the most rapidly increasing types of cancer in the United States and other developed countries, and no new treatments or no new drugs for head and neck cancer have been approved in over 10 years. I believe that head and neck cancer represents an ideal target for the immune system. Like other infections, the immune system can potentially attack virally related cancers. This attack can occur on many fronts. Vaccines can be used to prevent virally related head and neck cancers from developing. Immune therapies can target virally related proteins that are different from the normal proteins in the body and therefore can be specifically targeted. Chronic viral infections are also likely more dependent on immune checkpoints such as PD-1 and its ligand, which is called PD-L1. As you can see, the picture on the right is a slide looking at a head and neck cancer that's related to the HPV virus under the microscope. And when this slide is stained for the PD-L1 protein in brown, you can see that this cancer, and indeed many HPV-related head and neck cancers, express the PD-L1 checkpoint, and so can potentially be targeted by checkpoint inhibitors. Non-virally related cancers can also be targeted by the immune system. Indeed, tobacco and alcohol cause mutations over time that can also be potentially identified by the immune system to stimulate immune-mediated attack on cancers. To talk about some of these approaches in more detail, there are two approved vaccines, Gardasil and Cervarix, that prevent HPV infection. Although these have been most comprehensively studied in cervical cancer so far, more and more data suggests that these vaccines also prevent oral HPV infection and are therefore likely to prevent HPV-associated tonsil and tongue cancers over time. Unfortunately, however, these two vaccines don't treat HPV infections once they have occurred or cancers once they have developed. However, there is active research looking at vaccine strategies that are able to treat active cancers. Moving on to other immunotherapy strategies, as most people probably know, there is huge excitement in the field of oncology for PD-1 inhibitors, which are a type of immune checkpoint therapy that I mentioned earlier. In head and neck cancer specifically, promising early studies using PD-1 and PD-L1 inhibitors have been presented at recent medical conferences over the last several years. For example, data from the Keynote-12 study was presented by Dr. Tengay Seward at the American Society of Clinical Oncology meeting in 2015. This study included 132 head and neck cancer patients with demonstrated PD-L1 expression treated with an antibody called pembrolizumab, which blocks the PD-1 receptor. Most of these head and neck cancer patients had received more than one prior treatment for their cancer. And this study found that the treatment with pembrolizumab was well tolerated, with some expected immune-related side effects. 50% of patients in the study had disease control, which means their tumors ceased to grow, and 25% had a significant response or shrinkage of their tumor. Overall, 51% of patients that were evaluable had a decreased tumor burden. More early trial results were presented for durvalumab, which is an inhibitor of the PD-L1 protein, by Dr. Neil Siegel and colleagues at the American Society of Clinical Oncology meeting in 2014. Patients enrolled in this study didn't need to have tumors that expressed PD-L1. Again, this treatment was well tolerated by the patients who were treated in this study. And among the 54 head and neck patients that were evaluated, there was a 14% partial or complete response rate and a 32% disease control rate. And what was very interesting and very promising is at the time of the presentation, there were prolonged responses where many patients continued to receive the drug and continued to respond, suggesting that in head and neck cancer, as in other cancers, immune therapy might really lead to durable or long-lasting responses. Finally, most recently, earlier this month at the American Association for Cancer Research's annual meeting, results from the Checkmate 141 study were presented. This study demonstrated that PD-1 inhibition with another antibody called nivolumab improved survival as compared with chemotherapy or targeted therapy. In fact, this study was so successful that it was stopped early, not because there was any problem with the study, but because it had shown its benefit in terms of improving overall survival at an early time point. Indeed, survival at 1 year was more than twice as high with nivolumab as compared with standard therapy at this 1 year mark. So to summarize, head and neck cancers need to escape the immune system to develop, and this often involves chronic viral infections and immune checkpoints. We know that HPV vaccines may prevent certain types of head and neck cancer if they're given early enough, and we know that immune checkpoint therapy is a promising treatment for head and neck cancer patients. Moving forward, an exciting array of clinical trials are actively exploring how to use immune therapy even more effectively in head and neck cancer patients. And I just wanted to highlight a few of many potential approaches. For example, our group here believes there's a unique opportunity to combine immune therapy with other standard therapies, such as radiation and chemotherapy, to potentially improve results. Indeed, we recently found clues that radiation might help some melanoma patients who might not otherwise respond to immune therapies, such as the checkpoint blockade agent ipilimumab, and we'll soon be testing this hypothesis in head and neck cancer patients. Other studies are testing the role of immunotherapy before surgery or in patients with less advanced stage head and neck cancer. As I mentioned, surgery in the head and neck can cause significant side effects. So potentially treating with immunotherapy before surgery can potentially shrink the tumor, and also allows for the collection of tumor specimens where we can study the effects of immunotherapy in more detail to better create clinical trials and treatments in the future that help capitalize on immune attack on tumor cells. There's also some data, especially in other types of cancers, that patients that have received fewer prior treatments may respond better to immune therapy. Therefore, there's a lot of interest in testing immune therapy in head and neck cancer patients with earlier stage diseases. Finally, we're starting to expand the use of immune therapy across the spectrum of head and neck cancers that I mentioned earlier. And I wanted to talk specifically about two, specifically Merkel cell and salivary gland cancers. As I mentioned, Merkel cell cancer is a skin cancer that often occurs in the head and neck that can be virally related, just like other types of head and neck cancer. Data published last week in the New England Journal of Medicine demonstrated that PD-1 blockade, again with the antibody called pembrolizumab, causes responses in the majority of patients with this rare type of cancer. Finally, regarding salivary gland cancers, with the help of the Adenoid Cystic Cancer Research Foundation, we recently presented data that a rare but aggressive type of salivary cancer, adenoid cystic cancer, could also be a good target for PD-1 blockade, and a clinical trial to test this is also in development. So to conclude, tumor immunotherapy has come a very long way, and I think head and neck cancer patients are really beginning to see the benefits. There is still a long way to go, because I think that despite the success, we've only really touched the tip of the iceberg, and that the future immune therapies and combination of immune therapies and other treatments will help benefit many more patients, and specifically many more head and neck cancer patients, in ways that we never thought possible before. So thanks. I'm happy to take any questions.
All right, fantastic. Thank you so much, Dr. Schoenfeld. And I'll remind all of you who are watching right now that you can submit your questions now by typing in the Q&A box. Several of you have done so already, so thanks so much for those questions, and we'll get to them as quickly as we can. So Dr. Schoenfeld, when you were describing some of the results of clinical trials of immunotherapy for head and neck cancer, you included something called disease control rate. Now, can you explain to the viewers, many of whom are patients or caregivers, what does disease control mean within the context of immunotherapy, and is it unique to immunotherapy?
Yeah, no, I think that's a good question. So, you know, in clinical trials, we look at there are a lot of different important factors that we look at to determine whether a new drug or a new immunotherapy that we're testing is successful. Obviously, the most important and the one that we care the most about in most cases is survival. Does the treatment that we're trying, does the immune therapy help patients to live longer? And the problem with trying to examine this right away is that it takes a while before clinical trials can give us data about how well the treatment increases or may not increase survival of the cancer patients being treated. So we try to look for earlier clues that the therapy that we're testing is effective. We look at response rate, which is how often the tumors shrink significantly, using scans to measure this. But for immunotherapy particularly, and for other types of new treatments that we test, sometimes it doesn't take a significant response or a significant response right away to really help us, to give us the best estimate of how effective this treatment is going to be. Because sometimes, as we're learning, especially with immune therapy, you can have patterns of response where the disease may not shrink right away, or it may just remain stable, but that doesn't mean that the drug isn't working. And so we look at other things like disease control, where maybe the tumor hasn't shrank significantly enough to call this a clinical response by the definitions that are standardly used, but the tumor also hasn't grown, and maybe it's remained stable over many months or over many scans. And so we look at other measures such as disease control, which helps give us an early clue whether these treatments are going to be effective. And for immune therapy, some of these treatments have shown impressive disease control rates, and that have eventually translated into improved and long-term survival, even before we see significant responses or shrinkage.
There are certainly many examples of that where a patient's tumor doesn't disappear completely, but the patient's immune system seems to be able to keep it in check over the long term so that it no longer is life-threatening, or certainly not immediately life-threatening. That's one of the things about immunotherapy that I particularly find very fascinating. So as you know, patients who are going through treatment and often spend, either they or their caregivers spend a lot of time combing the internet or talking with their doctors to learn as much as they possibly can about their treatment options. And in the course of doing that, become very well versed in the nuances of treatment. So I have a question that I'd like to share. It's a little complicated for people who may not have gotten to this level of understanding of the different treatment options. So I'll ask you to kind of break it down for us, and it has to relate to with IgG1, IgG2, and IgG4 isotypes. So you have ipilimumab, which is an IgG1, tremelimumab, IgG2, and nivolumab, IgG4, and pembrolizumab. So what is, first of all, what is an IgG number? What does that mean? And how are they different? And do we see any different patterns of effectiveness in patients based on that?
Yeah, so I think there's a lot of components to that question. I mean, as I think I mentioned, to kind of take a step back, all of the checkpoint inhibiting drugs are antibodies. So they block these checkpoint receptors, and that's what IgG means. I mean, that's a type of antibody. But there's different classes of IgG molecules, and they function in slightly different ways in the body. And we're still learning about what's important for these drugs and how they work in patients. But one of the key important differences is some of these different IgG molecules can lead to something called antibody-dependent cytotoxicity. So if they bind to their target, so if, for example, ipilimumab binds to the CTLA-4 receptor, just that binding might block signaling through the CTLA-4 receptor. But certain types of these IgG molecules might not just block the signaling through the CTLA-4 receptor, but they also might lead to a process that causes the cell that's expressing this receptor to die over time, because the IgG molecule and certain classes of the IgG molecule are able to recruit other cells, to recruit other mechanisms that leads to the death of the whatever cell is expressing the receptor. And that could be potentially important, because one of the things that we're learning about the immune system and about T cells, and what we've learned over the last several decades, is, like I said, there are many different flavors or different types of T cells. And not all T cells are good. There are some T cells called regulatory T cells. These T cells, just as the good T cells might help kill a cancer, regulatory T cells might inhibit the good T cells from killing the cancer. And so that maybe one of the important functions of the antibodies that are successful, like ipilimumab, is that it's not just blocking the function of the CTLA-4 receptor, but it's also recruiting these other pathways that help eliminate these inhibitory cells, like the regulatory T cells. So I think that's the best way to think about these different classes and what we know currently about what might be the differences in how they work.
Clearly, immunotherapy and the immune system is very complex, but I think we're learning that it takes a system that complex to keep up with cancer, which can be equally as complex. So I guess the next question I have is from a patient. I believe it's a patient. Sorry if I'm wrong in that. submitting a question wondering about any treatments, any immunotherapy treatments for patients that have squamous cell cancer of the tongue that's not related to HPV, and isn't caused by any other of the kind of behaviors like smoking or alcohol that can cause the mutations that result in those types of cancers.
Yeah, so right now, squamous cell cancers are the most common type of cancer overall in the head and neck. They occur in many of the places that I talked about, including the tongue. Some of them, especially on the back of the tongue, what we call the base of the tongue, can be related to the human papillomavirus, but some are not, and many in the front of the tongue, the oral tongue, are not. And many are related to tobacco and alcohol. There's some that that don't seem to be related to the virus, and people who don't have a significant history of smoking or alcohol use, and we're still learning about what might cause these cancers. I think right now for immune therapy, many of the studies that I talked about have included squamous cell patients with squamous cell cancers of all different types. Those that are caused by the human papillomavirus and those that are not, those in people who have smoked and those in people that have not, never smoked. And, I think right now we don't know which of those factors is the most important in predicting which patients will respond to immune therapy and checkpoint blockade, although we're slowly getting more and more clues. And right now, I think clinical trials, or the majority of clinical trials that are testing immune therapy and checkpoint blockade in head and neck cancer patients, include a range of patients with squamous cell cancer, and not just those that are related to smoking or HPV virus. So I think that is a potential option, especially on a clinical trial.
When a patient is diagnosed with some form of head and neck cancer, at what point, right at that point of diagnosis, should the subject of immunotherapy be raised? Or is it something that should come later on in a patient's treatment?
So I think, up to this point, most of the clinical trials and still most of the ongoing clinical trials are in a patient whose disease has spread, and not as many patients who are recently diagnosed. But I think that's changing. There are now more and more clinical trials that are testing immune therapies at earlier stages in patients that are newly diagnosed, as well as patients with head and neck cancer that have been previously treated. So I think that's a discussion that patients should have with their oncologists, and I don't think it's too early to have that discussion right from the very beginning, because there are new clinical trials in development, and this is a rapidly progressing field where I think there are a number of exciting clinical trials that are being developed for patients with earlier stages of cancer that have never been treated.
I don't know if you can answer this next question, but you're at one of the world's premier research hospitals and networks of research academic institutions. So of course you're on the cutting edge, and patients who come to you are exposed to that cutting edge therapy, and that's one of the really wonderful things about clinical trials. But how aware of immunotherapy as a treatment option would you say the community oncologist who isn't at a major academic center, how aware are they of this?
Well, I think that depends. I think there's certainly very many oncologists who are practicing not just at major academic institutions, but also all over, that are very familiar with the clinical trial landscape across the country. And there are a lot of resources both for oncologists as well as patients to find out more about potential trials, on the internet and in other places.
That's good. So we have found sometimes that a patient may go to his or her doctor, and the doctor might not be aware of immunotherapy. So it does happen from time to time. And as you said, there are excellent resources available. So it sounds like it's always a good idea to do a little bit of homework when you're considering your treatment options. So earlier you talked about, and this is unfortunately going to have to be the last question before we go, but I think it touches on an important differentiator, something that really makes immunotherapy different from other forms of cancer treatment, and it's something called pseudo progression. So you hinted at this perhaps when you brought up the delayed response in some patients. Can you talk about what is pseudoprogression, when does it happen, and what does it mean for patients?
Yeah. So as we've gotten more experience with immune therapies, and particularly in other diseases like melanoma, we've learned that these don't act like traditional chemotherapy or radiation, and that some patients may have tumors that appear to actually be flaring or growing slightly in size before they start to respond. And we're still learning about what causes that, but one way to think about it is maybe you're stimulating the immune system to respond to the cancer. And so while you get these T cells and other immune cells and inflammation in the tumor that's about to respond, it may not look like it's responding because we obviously can't tell that from a CAT scan or a PET scan or any of the other imaging that we do. So this is what we call different, atypical patterns of response, and that's certainly something that's been seen and described in melanoma. I think we're still learning about how much that applies to head and neck cancer, but it's certainly, I think, something that we're getting more familiar with, and we know what to look for, and it's something that is being explored in head and neck cancers and other cancers.
Well, thank you so much for this very informative webinar, Dr. Schoenfeld. I know it's going to be of great help to patients who are considering options of treatment with immunotherapy. Once again, I would like to thank the generous sponsors of today's webinar, Genentech and LabAnswer and its employees, and also the following. I'd also like to thank our friends at the Head and Neck Cancer Alliance that have helped to spread the word about today's webinar to make sure that this information reaches the patients and the caregiver communities that need to hear it the most. So thank you very much for your support. If any of you are interested in learning more about immunotherapy for head and neck cancer or for other types of cancer or just about immunotherapy in general, the Cancer Research Institute has a website designed just for you. It's at www.theanswertocancer.org. Information, as I said, about various types of cancers. We also have a large library of stories, both written and video stories, of patients sharing their experiences of treatment with immunotherapy. And we also have a clinical trial finder service that's focused exclusively on immunotherapy. So if you're looking for an immunotherapy trial for head and neck cancer, you can call this number and a navigator will help you locate a trial for which you may be eligible. I'm also proud to announce that the Cancer Research Institute recently partnered with Inspire.com, one of the world's largest online patient communities, to create the first ever immunotherapy-focused community on the Inspire.com website. So you can go there at bit.ly/InspireCRI to be connected to the community and all the members of that community who are engaged in dialogue around immunotherapy. With that, I'd like to thank you again, Dr. Schoenfeld, and all of those of you who joined us for today's webinar. I forgot to mention that this webinar has been recorded and will be made available on the CRI website and on our YouTube channel. And we'll be pushing it out via our social media. So be sure to follow us at Cancer Research on Twitter. You can also view this and other webinars that we've done in the past at cancerresearch.org/webinars. And in just a moment, when we close the room, you'll receive a survey, and we hope you'll take a moment to provide your feedback. We'd like to make sure that we are providing the most valuable and informative webinar series to you as we possibly can. And with that, thank you all for joining us.